Hello everyone. I'm happy to see all of you today on 22nd of August 2025 for the ICOG Masterclass on Caesarean Section. And it's great privilege to see you all. Today my topic is impacted fetal head, and I dwell on certain features which I have experienced in the 35 years of my practice. And I'm sharing you the art of delivering impacted fetal head. Patience, persistence, and perspiration make an unbeatable combination for success. It's very important that as an obstetrician, when you are dealing labor patients, you have to have these three qualities. And that's what I learned when I started my residency 34 years ago in the Premier Institute of Science Hospital, where I am still a professor and unit head in the Department of Obstetrics and Gynecology. The overview of my impacted fetal head lecture is having to know about the introduction of impacted fetal head, its incidence, what are the risk factors causing it, the complications which we come across, and how you manage an impacted fetal head, and the conclusion. That's how will be the overview of my lecture. As we are aware, the Caesarean section rate has tripled or more than that in the last 2 decades. And globally, we are sailing in the same boat as others. But impacted fetal head remains an enigmatic obstetric emergency, which can come suddenly as we go ahead with the progress of labor, and it can further complicate the mother and the baby. So it's very important, but it's unfortunately does not have a clear definition in the literature. I will take you one by one various organizations which have defined it. So here you have American College of Obstetrician and Gynecologist, which says that a head that is deeply wedged in the maternal pelvis at the time of cesarean delivery, such that the elevation and delivery are technically difficult. While the RCOG in 2023 says that in spite of the usual techniques of gentle traction and elevation, in such a situation, especially in cesarean birth, where the obstetrician cannot deliver, and that causes impacted fetal head. While the NICE UK 2023 defines it as a difficult delivery in a caesarean section, potentially associated with complications for both the mother and baby. While the FIGO 2021 consensus says that it is usually seen in obstructed or prolonged labor, and especially when the fetal head has undergone full dilatation and the baby cannot be delivered in spite of a maternal pelvis being fine or borderline. Thus, life is full of difficulties, and it has got varied definitions of impacted fetal head, but we need to meet these challenges, greet them, and defeat them. And that's what we are here today to learn about impacted fetal head. Now, as per the management of impacted fetal head at Caesarean section, that is the MIDAS UK obstetric surveillance system, which was conducted from 1st of March to 31st of August 2029, it is estimated that 1 in 10 unplanned Caesarean deliveries have an impacted fetal head, while around 16% of Caesarean sections done at full dilatation face difficulty in delivering the fetal head. So you can see that overall, because of the increase in the trend of Caesarean delivery worldwide, we have further increase in the impacted head incidence. Now let's come to the risk factors. We have labor related factors, we have maternal fetal related factors, and then we have complications. So let's go through them one by one. So most commonly is an obstructed labor or a prolonged labor. So you have persistent occipito posterior where the occiput and the sinciput hits the pelvic floor at the same time, and then it doesn't undergo rotation, and then further full dilatation occurs, and then it can lead to obstructed labor. And then we have certain cases of prolonged second stage of labor, and even in patients who have undergone instrumental vaginal delivery, either by vacuum or forceps, and in spite of giving 3 tugs, there is failed instrumental delivery. Unfortunately, also, if you have an oxytocin drip which is not monitored appropriately, or it is at a faster rate, causing strong uterine contractions, the pushing of the head is further down into the pelvis, and all this causes, importantly, an impacted fetal head. Regarding maternal related factors, nulliparity, there is a less pelvic compliance, small pelvic dimensions, cephalopelvic disproportions, obese mother, prolonged labor, difficult extraction, and later on, as the labor becomes prolonged, there is maternal exhaustion and poor maternal efforts in the second stage. All these contribute further to a deeply impacted head. Regarding fetal factors, it's more importantly an occipito-posterior or a deep transverse arrest, where at 3 o'clock or at 9 o'clock you have an arrest and further progress is not happening in labor. Asynclitism, a misjudgment of the fetal size, and wrong ultrasound being diagnosed of the fetal weight, and clinical diagnosis of fetal weight is misjudged, and you give this patient a trial and it's a macrosomic baby more than 3.5 kg, and even the most learned obstetrician can make this mistake, or most experienced obstetrician can have this problem. And a station which is +2 or equal to at the time of cesarean, and the head has come down, but now because of the deep transverse arrest or persistent occipito posterior, you take this patient for a cesarean section. Well, and then caput and molding further contributes it further to go down to +3, and I've seen up till +4. So all these fetal factors also contribute to a deeply impacted head. So as you go ahead and progress in your obstetric career, the greater the difficulty you encounter, the greater opportunities you get through to deal with them, and the greater the glory happens. And that's what we learn from our own mistakes and learn from our own experience and other colleagues' experience, that we do not want to repeat it. Now, what you don't want is very important. If you land up in such a situation and you try to deliver the fetal head, you panic, there is an obstetrician's dilemma, and there is obstetrician's tachycardia, and there is a misjudgment. All these problems can be caused, which while delivering this fetal head, you can cause an extension of the cervix, laceration of the cervix. There could be a laceration into the vagina, further extending into the uterine lateral wall, and you can have an extension with a massive amount of bleeding and a further involvement of the bladder, causing bladder injury. And this all can be problematic situation which you encounter later after the delivery or during the process of delivery. Hemorrhage is the worst scenario, and we come across in our situation where the patient lands up later on because of traumatic PPH or atony, and unfortunately there might be an extension further higher up causing ureteric injury. Very, very rare, but this also is been associated with the improper judgment of delivering an impacted fetal head, and all the causes can cause all these problems. Post-operatively, even after delivering impacted fetal head baby, you have a higher chances of increased risk of postpartum hemorrhage. And because of prolonged surgery and prolonged time involvement, or the patient is for a long time in labor, even if you do a PV examination in such cases, you find them hot vagina, there is big caput and molding there, and it's tightly impacted. Even if you try to put your fingers in between, it doesn't allow you to go, and it is a lot of difficulty. And that's where you can have this patient landing up with infection, and it could be amniotic fluid infection, it could be an endometrial causing endometritis infection, or there is infection, it can further go ahead and cause septicemia, wound infection. So all these problems have to be understood post-operatively. And the worst scenario is an undiagnosed or a silent hematoma in the broad ligament, which is missed. So you have to have always to see the paracolic gutters when you close the abdomen, and retroperitoneal space, and see how the ureters are also being fine and they move. When you just tickle them, there is a peristalsis been seen. Sometime you might have to also do an obstetric hysterectomy if you land up with an atonic PPH not responding to conservative line of treatment with multiple blood transfusions. And of course, later on, extension of this dissection and trauma can lead to much more adhesion formation. Fetal neonatal complications are also to be known to us. Well, so because of the difficulty in delivery of this fetal head, there is trauma to the fetal head. There could be injuries to the brain, to the skull bones. There could be fractures which can occur. There could be intracranial hemorrhage, cephalomatoma, and twisting of the fetal head, difficulty while delivering by all these maneuvers which I will be telling you. There could be stretching of the sternocleidomastoid or a brachial plexus injury. Facial injuries have also occurred by use of a forceps or a hand pressure. And of course, there is HI 1, 2, 3, which sets in by the time, or hypoxic, and unfortunately, a neonatal death occurring. So all this is very bad situation which we come across. Now we don't have to panic. We don't have to lose our cool. We have to be masters, and these difficult situations will be mastered by us. And that's how we will win the opportunities, as said by Winston Churchill. There is nothing to worry. Everything can be sorted out, and we have management techniques. The most important thing is the vaginal push method of disimpaction. It's a very simple method. Absolutely be ready. Ask your assistant that if you are dealing with such a situation beforehand, anticipate in your head and see that the assistant is ready with his fingers to push the fetal head upwards as it goes gently and disimpact. Once that disimpaction is occurring, you put your fetal hand into the fetal head between, the previous hand which has been put by the assistant, and just lift it up. You don't have to pull it up. If you pull it up again, it will tear the uterine. Extensions will occur laterally. Just slide your hand, lift it up, and let it come out. Be gentle. Always be gentle. I always tell my resident doctors to be kind hearted, empathetic, and gentleness. Don't do Narsimha techniques, not right. This is a beautiful video I would like to share with you. Have just a look. Simple 2 to 3 fingers, just post disimpact. First is disimpact. You can see the other hand going up and gradually lifting up with slight flexion. Okay, and then take it up. Never try to put your 2 fingers and pull, push, push, push. No, no, don't do that. So this is very important that you go ahead and understand the situation. Again, I'm showing you how you displace the fetal impacted head, and then with the other hand, Just do flexion and take it up, but never use two fingers. Okay. Now we come to Patwardhan method. He is our from our my own alma mater where I did my MBBS, St. GS Medical College, prominently known as KEM Hospital, Mumbai. Dr. Balachandra D. Patwardhan sir has coined this shoulder first technique. It has been reported in 1957 in the Jogi Journal. It's an article on Caesarean sections, and even now, RCOG and other world authorities are practicing and trying to incorporate it into their manuals of delivering a impacted fetal head by Patwardhan's method. And it's really great to see my own colleague Tim Draycott. He is there in UK, RCOG Vice President to be soon. So this is a very simple method. It's first you have, as soon as you make an incision, a fanel still incision, and you further proceed ahead into the uterine cavity, you make an incision there. You find that the shoulder comes out. Nothing to panic. Don't try to push. Take it out. Take the another shoulder. Both the shoulders are out. Then you go ahead and take the back and trunk out. Then the buttocks will come and then the lower limbs. A very simple technique. You don't have to do the push technique, and this is a very successful maneuver which we have practiced at Sion Hospital. Also, it is a modification of reverse bridge extraction wherein the arms are delivered first. As I said, we will just see the video here. It's more important to understand. Once you have made an incision onto the uterus, lower uterine segment, extend it gradually. You see that one shoulder is coming out. Let it become out. The next shoulder comes out. Remember, do not cause a fracture to the humerus. Okay. And you slide your two fingers. Now take out little some amount of push onto the belly. You just pull it out and zoom, the buttocks will come out. And then the lower limbs. Be gentle, be gentle. And then you cut the cord, clamp it, deliver the baby to the neonatologist. Baby cries, everything is fine. Well, so modified Padvardhan technique is also there, where in cases of occipito-posterior position, where the head is deeply engaged, we make an incision onto the lower uterine segment. The shoulders are usually found. One shoulder comes out by hooking the arm. Then you follow by the delivery of the same side leg, and then the opposite leg and the arm. And this is how you go in this fashion. And then the buttocks and trunk also follow gently with the traction on the legs, and finally the head is delivered. So this is a modification. If you cannot deliver both the shoulders together, you need to remove one shoulder, the same side of the leg, the contralateral leg, and then the shoulder. And this is how you modify the Patwardhan's technique. The fourth type of mechanism for such situations is the head elevator, and it's a silicon balloon device which has to be inserted into the through the vagina, and then it is going further just before commencing the cesarean section. So what does it do? As you know the cesarean section starts, it helps to elevate the head, and so as to make the delivery quicker and less traumatic. Well, this is not come now up till now in India, so let us see how things will be happening in future. And they also recommend tocolysis. Why? Because when you are delivering the head and there is a lot of stimulation, the uterus can undergo a reflex contraction, and it is challenging to manipulate the fetal head. So, in such circumstances, the decision is to give tocolysis. But it's very important that you have to weigh the pros and cons, the risk and the benefits, as this can lead to atonic postpartum hemorrhage. But surely this has some amount of say in your management, but it's taken with a pinch of salt. Well, this is the reverse breech extraction procedure, which is also known as the pull technique, where you cut open the lower uterine segment instead of the fetal head, which is low down, and you cannot even access the shoulders, and especially, you know, in a low resource setting, you try to go and try to feel the lower limbs, and you deliver the feet first, then the buttocks, then after the buttocks, the trunk, and lastly the fetal head. So it is the other way around. But here you have to be very importantly understanding that you do not cause any fractures to the humerus and the femur. So in conclusion, knowing all these different types of methods which we are trying to use in impacted fetal head, it's very important that you have to anticipate. There has to be a prompt recognition of such a situation. A proper technique, an appropriate technique has to be taken into consideration. You cannot start with one method, leave it halfway alone, go to another method. Be sure of what you want to do and proceed with that, and come to the ultimate goal of delivering the fetal head, and that it cries and goes to the neonatologist. A skilled intervention and experienced obstetrician is very important. Call for help, call your senior, be anticipating the situation and see that you call for help. And there are certain strategies which you have to learn, which you have to include in your procedure. Either of these techniques you can do, and depending upon the situation, either a tertiary center or a low resource center, go ahead with a multidisciplinary approach, blood transfusion being ready, transfer if required to higher center in cases of situations as I mentioned below, and previously like PPH, etc., or any injury to the cervix, vagina, or the uterus. So, in conclusion, what's important is my seniors in Sion Hospital taught me 3S and 1R. So, when you're doing a surgery, either obstetric or gynec, you should be safe. Whatever you do, there has to be gentleness in your surgery. It should be swift. You should be sure of what you know, what you're doing, and just continue at a spinal level. Relentlessly go on doing it. And my mother tells me, when she was alive, she used to tell me, Niranjan, you should have lion's heart, you should have eagle's eye, hawk's eye, lady's fingers, gentle, Doberman suspicion. Dr. Patkar added it, and I added yesterday, bulldog's bravery. It's very important that you have all these qualities when you go ahead to become a very good obstetrician and a gynecologist. I wish you all the best to all of you. And I end my lecture with this quote: out of difficulties, we grow miracles. And I'm sure all of you are going to grow miracles after this lecture and practice this maneuvers whenever you come across such bad situations in your career. Thank you so much for a patient hearing. And I thank ICOG chairman, the secretary, and the president, and all the office bearers and the conveners for inviting me today to speak on this beautiful lecture where I could share my experiences with all of you. Thank you so much, and I'm sure I'll see you soon in the near future. With this, I would like to conclude my recording. Thank you.